objectives of knowing time since death, because it will help the police for a starting point of investigation. Crime কখন হয়েছে সেটা বোঝা যাবে, আর enables to exclude or include suspects, to confirm or disapprove alibi, and to check suspect statements. So these are the reasons why time since death is required. তো একদিন এই 4-5টা ক্লাসে আমরা যা পড়লাম ডেতে, সবকিছু আজকে জিস্ট একটা হবে। ওকে, সো উই শুড ডু আ কুইক রিক্যাপ। কোশ্চেনটা ইম্পর্টেন্ট, কোশ্চেনটা পড়ো। A man was found dead on the roadside in March. They brought the body to hospital. The body, after due process, was shifted to the morgue. So, এই লাইন থেকে আমরা কি কি ইনফরমেশন পাচ্ছি? The body was found in March. Season? March কি? Summer. আমরা চারটা ঋতুতে যাব না, দুটোতে কনসেন্ট্রেট করব, উইন্টার এন্ড সামার। ওকে, সো when I say season, it is summer. এছাড়া কি পাচ্ছি? The body was brought to hospital. হসপিটালে কে আনবে বডিটাকে? যে কেউ আনতে পারে, হ্যাঁ, পাবলিক বা পুলিশ যে কেউ আনতে পারে। আফটার দ্যাট the body, after due process, was shifted to morgue. Now a due process, who will decide whether to conduct postmortem or not to conduct postmortem? Who will decide? Doctor, police, public, or everybody agree? Police? Hi or no? Have an answer, yes but no? Yes, কতজন লোক? হাত ওটা হাত। আজকে তো ইন্টারেক্টিভ সেশন হবে। ইয়েস, আর বাকিরা কি না? পুলিশ বলবে না, ডাক্তার বলবে? পুলিশ বলবে। ফাউন্ড ডেড ইন মার্চ, ঠিক আছে, অ্যাট বোলপুর। দ্য বডি ওয়াজ ব্রট টু দ্য হসপিটাল। দ্য বডি আফটার ডিউ প্রসেস ওয়াজ শিফটেড টু দ্য মর্গ। তাহলে এখানে ফার্স্ট লাইনে কি জানলাম? মার্চে একজন মারা গেছে, সামারে মারা গেছে, বাইরে বডি পড়েছিল। ওকে, দুটো ইনফরমেশন পেলাম। বডি হসপিটালে নিয়ে এসছে, কে নিয়ে আসলো? আচ্ছা, হু উইল ডিসাইড টু ডু পোস্টমর্টম? পুলিশ, রাইট? এখন একটা ডেথ হয়েছে, তার পোস্টমর্টম হবে। এই প্রসেস অফ ইনভেস্টিগেশন ইজ কল্ড অ্যাজ ফরেন্সিকের ক্লাস। হ্যাঁ, কে একজন অ্যান্সার বললো? এই প্রসেস অফ ইনভেস্টিগেশন ইজ নোন অ্যাজ ইনকোয়েস্ট। Types of inquest that happens in India? এটা তো আমি রোজ প্র্যাকটিক্যাল ক্লাসে জিজ্ঞেস করি একবার একবার করে। হ্যাঁ, পুলিশ ইনকোয়েস্ট অ্যান্ড ম্যাজিস্ট্রেট ইনকোয়েস্ট, ঠিক আছে না? পুলিশ ইনকোয়েস্ট অ্যান্ড ম্যাজিস্ট্রেট ইনকোয়েস্ট, আরো অনেক কটা ইনকোয়েস্ট টাইপ আছে, বাট দিস টু আর কন্ডাক্টেড ইন ইন্ডিয়া। সো কই নেই। সো একজন মারা গেছে, সামারে মর্গে পিএম হচ্ছে। সো লেটস সি হোয়াট উই ফাইন্ড। While examining, it was found that the eye of the deceased was partially open. Okay, eye was partially open, and there were triangular shaped discoloration on the sclera. To check that, the examiner tried to open the eyelids and opened them very easily. The cornea was found hazy. কি information পেলাম? এক্সাক্ট রিয়েল লাইফ, আমি কিন্তু এটা বসে বসে বানিয়েছি। সো হ্যাঁ, চোখটা খুলছে, রাইট? তার মানে কি? চোখ খুলছে মানে কি? ইজিলি অলসো। হ্যাঁ, বেঁচে আছে না, ও খুলছে না, এক্সামিনার খুলছে। চোখটা, চোখ লিড ইজিলি খুলছে মানে কি? বেশি টাইম হয়নি। ওকে, পসিবিলিটি ইজ দেয়ার। এনিথিং এলস? আচ্ছা, ঠিক আছে, আমরা এই পয়েন্টটা হচ্ছে উই উইল টক অ্যাবাউট দ্যাট আ বিট লেটার। আর কি কি পেলাম? এই যে ট্রায়াঙ্গুলার শেপ ডিসকালারেশন অন দ্য স্ক্লেরা, হোয়াট ইজ দিস? লাস্ট ক্লাসেও জিজ্ঞেস করলাম, দেখালাম, তার আগের ক্লাসেও দেখালাম, তার আগের ক্লাসে পড়ালাম, কি রে? Sign of? What is it called? Okay, I will show you in the next slide. তো আমরা এখান থেকে একটা জিনিস পেলাম, চোখ খুলছে and cornea is hazy, right? Now, next, the height of the body, that is dead body, was noted. The wearing apparels are noted. There was dirt on the shirt and pant on the front side, সামনের দিকে. The pant was torn at knee with dried stain of blood. The examiner found a broken watch, a watch that stopped working and was showing a specific time. কি কি ইনপুট পেলাম এখান থেকে? শুরু থেকে বল, কি কি ইনপুট পেলাম? আচ্ছা, height of the body, is the statement correct or wrong? How many of you think height is correct? Answer बोलो यार. ठीक है, got it. पहुंच गई बात आपकी. Anybody else? Height হবে না অন্য কিছু হবে? Yes বা no? It will be length. Why? Horizontal এর জন্য না increase করার জন্য? Because of relaxation. Right? So length, not height. Just remember, not height, length. The length of the body is noted, wearing appearance noted, there was dirt on shirt and pant on the front aspect. আর হাঁটুর ওখানটা ছেঁড়া একটু রক্ত লেগে আছে. And apart from that, dried stain of blood. একটা ঘড়ি পাওয়া গেছে যেটা কিনা বন্ধ, একটা টাইম দেখাচ্ছে. এই অবধি ক্লিয়ার? Now, on examination, there was dark reddish discoloration of the skin of the chest and abdomen, frontal aspect, front side, which does not move on pressing. There was also a pale area on the front side of the chest. The abdomen was tight and also had greenish discoloration on both inguinal areas and the lower abdomen. The lower limbs were found to be comparatively stiffer than upper limbs. এবার আমাকে বলো, dark reddish discoloration of the skin and chest, front side মানে কি? ওকে, পুরো ব্যাপারটা ঠিক একটা কিরকম একটা হয়ে গেল. What happened? কি কি পয়েন্ট পেলাম আমরা? হ্যাঁ, what is it called first of all? আচ্ছা, প্রথম থেকে আসি. What are the signs of death? No sign. Side না, sign. হ্যাঁ, immediate, early and late. Immediate sign কিছু পাওয়া যাচ্ছে এখানে? No. Early? এই পুরোটা পড়ে. You feel free to answer. Please answer. নাহলে জিনিসটা কিরকম একটা অদ্ভুত হয়ে গেল. খালি পড়ি আর কি, বইতে তো লেখা আছে, পর বই থেকে. So this is the real life scenario that you have to face. এখান থেকে দেখে বলো, what is the কি early signs? Early signs এ আমরা কি পেলাম? cornea hazy, right? Agree? Partial open eye is not actually eye sign, ওটা eyelid. আচ্ছা, এছাড়া apart from that early sign কি কি আছে? Something called as postmortem staining. হ্যাঁ, তাহলে এইটা কি আমরা postmortem staining বলতে পারি? Dark reddish discoloration of the skin. আচ্ছা, এইসব বলে the police wants to know time since death. আমাদের কাজ এইখান থেকে time since deathটা বার করা. ঠিক আছে? লাস্ট ক্লাসে আমরা দুটো পিকচার ড্র করেছিলাম ফর ইউর ইজি আন্ডারস্ট্যান্ডিং. যাই হোক, তো এখানে হোয়াট ইজ ইট? পোস্টমর্টম স্টেনিং অন দ্য ফ্রন্টাল অ্যাসপেক্ট মানে কি? মানে উপরে পড়েছিল, রাইট? এগ্রি উইথ মি? আচ্ছা, এখানে একটা পেল কালারের একটা জায়গা রয়েছে, contact, that is contact pallor, and most probably it is the hand where wrist where watch was there. পড়েছে, ওয়াচটা stopped working. এই অবধি ঠিক আছে? Now, which does not move on pressing. Press করলে মানে postmortem staining is not moving. What does it signify? Postmortem staining, another postmortem staining. Press করলো, it is not moving anywhere. It is there. It means the postmortem staining has fixed. Fixed কখন হয়? Fixation of postmortem staining at 8 hours. That means 8 ঘন্টা ধরে বডিটা ওখানেই পড়েছিল। ওকে, নাও eyelids open হচ্ছে easily. What does that signify? হ্যাঁ, রিল্যাক্স আছে। তো রিল্যাক্স কখন হতে পারে? আর্লিতে একটা হতে পারে প্রাইমারি রিল্যাক্সেশন, সেকেন্ডারি রিল্যাক্সেশন, মাঝখানে রাইগার মর্টিস। তো রাইগার মর্টিসের কোন পার্টটা আগে হয়, কোন পার্টটা পরে হয়? রাইট, এখান থেকে যায় তো, রাইট? তার মানে সবার আগে 2 ঘন্টা আইলিড থাকছে, 12 ঘন্টা, 2 ঘন্টা পর ছাড়ছেও, রাইট? তার মানে আইলিড ইজ অলসো রিল্যাক্সড। আর লাস্ট লাইন, দ্য লোয়ার লিম্বস ওয়ার ফাউন্ড টু বি কম্পারেটিভলি স্টিফার দেন আপার লিম্ব। মানে কি, আপার লিমেও রাইগার মর্টিস আছে, স্টিফ একটু, বাট লোয়ার লিম্ব মোর স্টিফ। তার মানে কি, ইট ইজ প্রবাবলি রাইগার মর্টিস ইজ পাসিং অফ। এগ্রি? রাইগার মর্টিস ইজ পাসিং অফ। নাও অ্যাপার্ট ফ্রম দ্যাট, এই যে abdomen is tight. What does it mean? Abdomen tight মানে কি? হ্যাঁ, আসছে, থাকছে, যাচ্ছে, সেম প্রসেস। ওকে, নাও abdomen tight মানে কি? Exactly, gas. What is it called? Not bloating. Bloating পুরোটা, সব যখন ফুলে যাচ্ছে, এন্টায়ার থিং ইজ ব্লোটিং। সব ফুলে যাচ্ছে মানে ফেস ফুলে যাচ্ছে, আই প্রপড আউট হচ্ছে, টাং প্রট্রুডেড আউট হচ্ছে। সো দিস আর এন্টায়ার থিং ইজ কল্ড এজ ব্লোটিং। ডিগ্রি অফ ব্লোটিং অত আমরা যাবো না, বাট ব্লোটিং মিনস দ্যাট এন্টায়ার থিং। তাহলে এটাকে আমরা কি বলবো? অ্যাবডোমেন ডিস্টেনশন, ঠিক আছে? তো ডিস্টেন্ডেড অ্যাবডোমেন কখন হয়? আচ্ছা, অ্যাপার্ট ফ্রম দ্যাট, ডিসকালারেশন অফ বোথ ইনগুইনাল এরিয়া and lower abdomen, মানে what is the earliest external sign of decomposition of কোথায় located where? greater location, greater, right? greenish discoloration of right inguinal region is the external earliest sign of putrefaction. ঠিক আছে? ভেরি কমন কোশ্চেন। তাহলে এখান থেকে আমরা কি কি পেলাম? সো মোটামুটি আমরা দেখলাম কি কি পেলাম এখান থেকে। ফার্স্ট, কর্নিয়া হেজিং 6 ঘন্টা আফটার ডেথ। ওকে, আচ্ছা, নাও হিয়ার দিস ইজ, হোয়াট ইজ ইট কল্ড? কি? স্যাশে নয়ার, ট্যাকে নয়ার, হোয়াট এভার। আচ্ছা, এইটা দেখ, হোয়াট ইজ ইট? Postmortem staining with contact pallor, and here greenish discoloration lower abdomen. তাহলে কি কি আমরা পেলাম? আবার বলো। কর্নিয়া হেজি, হ্যাঁ, নাও কর্নিয়া হেজি 6 hours। আচ্ছা তো সবাই, all with me? So we are finding the time since death of a real life scenario. আচ্ছা, this is what we do in practical. প্র্যাকটিক্যালে আমরা এরকম ভাবে দেখি টাইম সিন্স ডেটটা বার করি, এন্ড দিস ইজ হোয়াট উই রাইট। সো এগেন, কর্নিয়া হেজি সামারে হচ্ছে কর্নিয়া হেজি, রাইট ইনগুইনাল রিজিয়ন গ্রিনিশ ছিল, কিন্তু লেফটেও আছে, লোয়ার অ্যাবডোমেনও আছে। তার মানে 12 ঘন্টা তো হয়েই গেছে, 12 থেকে 18 মধ্যে হয়। এবি মানে অ্যাবডোমেন ব্লোটিং, ডান। কিন্তু মার্বলিং পাইনি। মার্বেলিং পেয়েছে কি? মার্বেলিং নেই। ব্লিস্টার্স নেই, তার মানে আমরা বলবো 36 আওয়ার্স এখনো হয়নি, রাইট? ওদিকে রাইগার মর্টিস এসছে, ছিল, যাচ্ছে, মানে আই ইজ গন, লোয়ার লিম্বসে এখনো আছে, তার মানে 36 আওয়ার্স এখনো কমপ্লিট হয়নি। সো হোয়াট ইজ দ্য প্রবাবল টাইম সিন্স ডেথ অ্যাকর্ডিং টু ইউ? 24 to 30? কি 30? range 24 to 36 can be said. So আমি হলে বলতাম 18 থেকে 36, 18 to 36 more broader, more safer, but 24 to 36 also good. তাহলে কি করে আমরা আরো টাইমটাকে শর্ট করব? দেখে দেখবো লিভারের কন্ডিশন, রাইট, ট্র্যাকিয়া এন্ড ল্যারিংসের কন্ডিশন। ইফ দে আর ডিকম্পোজড তাহলে আমরা আরেকটু ওদিকে যেতে পারবো। সো ওকে, সো দিস ইজ হাউ উই ফাইন্ড টাইম সিন্স ডেথ। নাও আচ্ছা, হোয়াট ইজ দ্য আর্লিয়েস্ট ইন্টারনাল সাইন অফ ডিকম্পোজিশন? এটা আমি আগের ক্লাসে বলিনি, বাট ইফ ইউ হ্যাভ রেড, যদি বাড়িতে গিয়ে পড়ে থাকিস, ইন্টারনাল সাইন, এক্সটার্নাল না। গ্রিনিশ ডিসকালারেশন অফ আপার লোব অফ লিভার, ঠিক আছে, লাস্টে দেখাবো আরো। নাও এরপর আমরা আরো কি কি করতে পারি? দ্যাট উই ডোন্ট ডু বাট উই ক্যান। এনি আইডিয়া? আরেকটা কিছু লাস্ট ক্লাসে বলেছিলাম। এনিথিং এলস টু গেট আ স্পেসিফিক মোর অ্যান্সার? টেম্পারেচার, we can take temperature, rectal temperature, temperature of the body minus rectal temperature divide by rate of fall of temperature. যেহেতু এটা সামারে হচ্ছে, divide by 0.75. Okay, this will give a more specific answer. Apart from that, what can we do? Apart from that, what can we do? We can take blood. নিতে পারি কি নিতে পারি না? Yes or no? আরে হ্যাঁ या না তো বলো। নিতে পারো। CSF, আচ্ছা, before we go to CSF, we come to gastrointestinal tract. Now we are conducting postmortem. So কি কি types of incision হয় পরে আসবো। As of now, we have given an I-shaped incision from here to there, and now we have opened peritoneum, আমার সামনে আছে স্টমাক। So what we will see from stomach? কি কি স্টমাকে আমরা দেখব? এক, স্টমাকের আর্কিটেকচার। সেকেন্ড, স্টমাকটাকে কাট ওপেন করব। We will see the contents of the stomach. We will see mucosal layer of the stomach. Okay? So now contents. আচ্ছা, how many of you are diet conscious, health conscious? সবাই health conscious, very good. খাবার কত ঘন্টা পরে শোয়া উচিত? 1 ঘন্টা? Yes, that is why. इसीलिए ये हालत है. Good. 3 hours. Who said 3? 3 कौन बोला? हाथ उठाओ. 3. Why 3? Agree with her? Dietitian বলেছিল 3 hours. Very good. You have a dietitian? Very good. Now, so dietitian told 3 hours. Why he or she told 3 hours? Any idea? Because of gastric emptying, stomach emptying. Generally, liquid empties within 2 hours after intake from stomach. Solid exits within 4 hours after ingestion. যদি লাইট মিল হয় 2 hours, হেভি মিল হয় 4 hours, মিডিয়াম হলে 3 hours. So rule of thumb, 3 to 4 hour পর খাবার, 3 to 4 hour খাবার খাওয়ার পর ঘুমানো উচিত। Okay? Now, if someone is having alcohol, then that gastric emptying will be দেরিতে হবে। So যদি আমি পোস্টমর্টম করার সময় স্টমাক ডিসাইড করে দেখি পেটের মধ্যে খাবার আছে, what does that signify? রাইট, তার মানে 4 ঘন্টার পর খাবার খাওয়ার 4 ঘন্টা পর there is a probability that the deceased were not alive. এগ্রি এগ্রি করা আছে? যদি পেটের মধ্যে খাবার থাকে, আচ্ছা পেটের মধ্যে কি কি খাবার থাকে সেটাও আমাকে দেখতে হবে। You have to write how it looks, if you are finding what kind of food, not taste it, you can smell it. You should smell it to find out what? Smell the stomach content of the deceased to find out any specific smell of any poison or alcohol. কি খেয়েছে তার উপর ডিপেন্ড করে। অনেক সময় ইয়েলোইশ মিক্সড ফুড পাওয়া যায়, অনেক সময় গ্রিনিশ ফুড পাওয়া যায়, অনেক সময় মাংসের টুকরো পাওয়া যায়। না কার্বোহাইড্রেট empty is 2 hours, protein 3, fat 4, like CPF. ওকে, সো এইসব দেখে আমরা একটা আইডিয়া করতে পারি। বাট হোয়াট টু ডু উইথ দ্যাট? আমরা জানলাম যে হ্যাঁ 4 ঘন্টা আগে মারা গেছে, দেন we need to know when he had dinner. Yes or no? কখন খাবার খেয়েছে জানতে হবে তো। How will you know? How will you know patient had eaten? জিজ্ঞেস করবে হিস্ট্রি। পোস্টমর্টম করার আগে জিজ্ঞেস করবে কখন কি হয়েছিল, লাস্ট কখন দেখেছেন, লাস্ট কখন খাবার খেয়েছেন, এরকম টাইপের জিনিস। খাবার খাওয়া ইজ ভেরি ইম্পর্টেন্ট বিকজ উই আর গোয়িং টু সি স্টমাক, রাইট? তো স্টমাক থেকেও আমরা, স্টমাক কন্টেন্টস থেকেও আমরা এটা বুঝতে পারলাম। নাও সিএসএফ, সিএসএফ কালেক্ট করা can be done but not easy in postmortem cases. Potassium will increase 20 hours. Blood, however it might sound easy but it is not easy to collect blood. ঠিক আছে, যখন আমরা পোস্টমর্টম প্রসিড করব then you will see it is very difficult to collect blood. Lactic acid will increase, amylase level will increase, LDH will increase, sodium will fall, and these changes happen. You have to mark it for exam purposes. Bone marrow, bone marrow biopsy করে দেখতে হবে, neutrophil nuclei will be swollen up within 1 hour, rounded within 4 hours, and vacuoles in cytoplasm will be seen at 10 hours. Academically very important, so mark it for exam purpose. But what is important is vitreous humor. আচ্ছা, এতক্ষণ আমরা যা পড়লাম বা আমরা পোস্টমর্টম রিপোর্টে লিখলাম, তার কি কোনো প্রমাণ থাকবে যখন তুমি যাদের কাছে যাবে? Yes or no? থাকবে কি? You could have taken photographs for প্রমাণ, but photographs will also not show the exact color, right? So প্রমাণ কখন থাকবে? When you have a test result, right? যদি তোমার কাছে ধরো সোডিয়ামের কত কনসেন্ট্রেশন আছে, we have a paper report, that is a praman, right? So now vitreous humor is very important with that respect. Why vitreous humor is very important, or why it is well preserved? Vitreous humor ta well preserved থাকবে কেন? Why, where is vitreous humor? So safe locations, কালারের ভিতরে, আই বলের মধ্যে, right? So chances of harming vitreous humor is less until and unless চোখটাতে injury হয়েছে, right? So what happens? Vitreous humor, potassium concentration when someone is alive is less, that is 5.8 millimole per liter in vitreous humor, but it is more in retina. After death, from retina potassium comes to vitreous humor. Now we can take vitreous humor and find out potassium concentration. The rate of rise is 0.17 to 0.238 millimole per liter. তো ওর জন্য ফর্মুলা আছে, ফর্মুলা ইজ মেডিয়া এন্ড হেসেঙ্গি ফর্মুলা। আরো 3টে ফর্মুলা আছে, জেমস এন্ড স্টুয়ার্ট আই থিঙ্ক, বাট রিমেম্বার at least this formula. Postmortem interval is equal to 5.26 into potassium concentration millimoles minus 30.9. With this you will get a time and that will be your post-mortem interval. ঠিক আছে? Now hypoxanthine levels are also there, you can also estimate, but এটা linearly 120 ঘন্টা ধরে লাইজ করবে। So potassium concentration is more specific. Apart from that, we will have pericardial fluid, we will have hairs, we will have synovial fluid. আচ্ছা, একটা স্টেটমেন্ট আছে, মরার পর চুল গজায়, মানে চুল বাড়ে। Have you heard that? Have you heard মরার পর চুল বাড়ে? হ্যাঁ না? Wrong or right? Huh? How many right? মরার পর চুল কি করে বাড়াচ্ছে? How many of you are right? Right. Okay. Now, this hair is also an important factor for predicting time since death. কি করে? Suppose someone is shaving করে মারা গেল। Why? I don't know how. But shaving করে মারা গেল। Now, if police comes with that shaved beard, and now I take the beard from the deceased and measure, ওই বিয়ারটা, deceased beardটা will be longer, a bit millimeters, but it will be longer. So, মরার পর তো hair বড় হচ্ছে। How it happens? It happens because of shrinkage of skin, not because hair is growing. ঠিক আছে? Skin shrink করছে, hairটা একটু বড় হচ্ছে। Not that hair is growing. Now, apart from that, muscle enzymes, you can also see those things. Radioactive carbon, C14, for in cases of this mummy tummy, archaeological findings. So this radioactive carbon dating C14 is done for case of archaeological findings. Scene of death. Body was found in December, brought to morgue. কোন season? Winter. While examination, it was found that dead body was soiled up at places. The body is greenish, blackish, discolored with blisters at places, and peeling of epidermis is noted. Marbling is seen on the chest wall. Upper limbs and lower limbs were flaccid. The hair and nails were intact. কি ইনফরমেশন আমরা পাচ্ছি এই কোশ্চেন থেকে? ফার্স্ট, উইন্টার। সেকেন্ড, সোয়েলড আপ হয়ে গেছে। আচ্ছা, গ্রিনিশ ব্ল্যাকিশ ডিসকালারেশন। আচ্ছা, কারা বুঝতে পারছিস না হোয়াট এভার আই এম সেইং? Anybody who cannot understand what am I saying? Because I want you to understand. Anybody? কিছু বুঝতে পারছি, কিছু বুঝতে পারছি না। না, entire thing is क्या फर्क पड़ता है? हाँ? अच्छा, कोई बात नहीं, किसी भी आंसर नहीं है। ঠিক আছে, নো প্রবলেম। তো বডি সোয়েলড আপ হচ্ছে মানে হোয়াট? ব্লোটিং। সো ব্লোটিং, ডিগ্রি অফ ব্লোটিং হতে পারে, but bloating has started, not entirely bloated up, but bloating has started. Entirely bloated up বলে কি করতাম? Eyes protruded, tongue. So bloating has started. Greenish, blackish discoloration, blisters, marbling. How many of you are acquainted with the term postmortem blisters? বুঝতে পারছিস কারো postmortem blisters? Peeling of epidermis is seen. Now, acha, upper limb and lower limb are flaccid. মানে rigor mortis আছে না গেছে? চলে গেছে। তো কতক্ষণ হবে? টাইম সিন্স ডেথ 36 আওয়ার্স হয়ে গেছে। উইন্টারে, এবার আমরা ওই স্লাইডে আসি। আর কিছু আছে না? ডিফারেন্ট সাইজ অফ ম্যাগটস। Important keyword, different size of maggots are seen around the body. We will continue with this, but আমরা এখন time since death বার করছি। তাহলে নাও, winter season, rigor mortis done, 36 hours, safely say 36 hours হয়ে গেছে winter এ। Now, RIF মানে right greenish discoloration হয়ে গেছে, অ্যাবডোমেন ডিস্টেন্ডেড হয়ে গেছে, মার্বেলিং ইজ সিন 48 hours, bloating blisters 3 days, but nail or hair কিন্তু preserved. Okay, so it is not 4 days এখনো হয়নি. So what will be the time since death depending on that? তো মার্বেলিং তো হয়েছে, বাকি তো হয়নি এখন। সেফ will be when? 48 to 72. I will go with 48 plus 12, that is 50 to 84. 54 to 84. ठीक है, इससे थोड़ा 12 ऐड कर देंगे, 12 50 होते ना, 60, हाँ 60 to 84. So just to be safe, 60 to 84. जाकि अच्छा, what else we will consider? So this is what we do. We don't take vitreous humor. আচ্ছা, আমি যখন প্রথম কালিম্পংয়ে গিয়েছিলাম আফটার আই পাস আউট, খুব উৎসাহী ভিট্রাস হিউমার চেক করবো। পরীক্ষা দিয়েছি, আই নো হাউ টু ডু, মানে পিজি পরীক্ষা দিয়ে आई वेंट टू सुपर, सर हमको विट्रियस ह्यूमर चेक करना है टू फाइंड आउट टाइम सिंस डेथ। सब नॉट गोइंग टू हैपन। व्हाई? प्रॉब्लम ये है आवर पॉपुलेशन एंड आवर इंफ्रास्ट्रक्चर। जिंदा लोगों का टेस्ट नहीं हो रहा, तुम डेड बॉडी का टेस्ट कहां से करोगे? सो दिस इज अ प्रॉब्लम, बट विथ 10 বছরের মধ্যে दिस कैन बी अ नॉर्मल थिंग। सो यू हैव टू नो from where to take vitreous, how to take, where do you know how to take and how to measure. So this is what we do in real life. এবার তুমি কি করবে? এবার তুমি ইনকোয়েস্টটা করবে। ইনকোয়েস্ট যেটা প্রিপেয়ার করছে, ইনকোয়েস্টের মধ্যে লেখা থাকে follow the events and there will be time, consult, take the history. Now is that history right or wrong? What do you think? History given by the patients, right or wrong? হ্যাঁ, ঠিক বলবে? বুঝতে পারছি না, আরেকবার বলো। হিস্ট্রি পেশেন্ট যেটা তোমাকে বলছে, I still can't get you. ঠিক হতে পারে, ভুল হতে পারে, এক্স্যাক্টলি রাইট। You presume ভুল because patients always lies. ঠিক আছে, you presume ভুল, আর তোমাকে ওর উপর ডিপেন্ড করবে না, but still you can take the history. ঠিক আছে, অনেকে বলে হিস্ট্রি নিয়ে তুমি ইনফ্লুয়েন্স হয়ে যাবে। নো, why should you get influence? শুনতে কি আসছে, এক কান্দি শোনা এক কান্দি বার করা, but you can take the notes. And if it corroborates, then you say. If it does not corroborate, then you say. রাইট কথা বলছি না, say to the police. তো এইসব করে যখন লিখবে, considering the physical findings of external and internal examination and inquest report and history gathered by asking patient relative, in my opinion, the probable time since death of the deceased is 60 to 84 hours from post-mortem examination. ঠিক আছে, এরকম ভাবে লিখবে। নাও লাস্ট লাইনটা কি পড়েছিলাম? Different sizes of maggots. So maggots is another chapter which is called as forensic entomology. What is it? It is study of insects for helping in administering justice. So now কিসে প্রিজার্ভ করা হয়? পুরানো একটু অ্যাসিডিক অ্যালকোহল। নাও ম্যাগটস যদি কোনো বডি এয়ারে আছে, আচ্ছা ক্যাসপাস দিকটা মনে আছে? 1:2:8, রাইট? বডি এয়ারে আছে, বডি ওয়াটারে, বডি বারিড, রাইট? তো এয়ারে থাকা মানে কি বডি? হোয়াট ডাজ ইট মিন? বডি এয়ারে আছে মানে এমনি পড়ে আছে, রাইট? সো when in open air, when body is in open air, then waves of insects comes at 8 waves. 8টা ওয়েভে আসে। But if they are buried, the insects will come in 2 waves. দুটো ওয়েভ কি কি? ফার্স্ট ওয়েভ ক্যালিফোরা, that is before burial, and second is phylonetes after burial. You will have to mark these things for exam, है ना? Califora and phylonetes open থাকলে 8টা ওয়েভে আসবে until and unless it is buried, আর burial হলে দুটো ওয়েভে আসবে, ঠিক আছে? Now so these are 8 waves. First week এ আসে মুস্কা and califora, second week এ second to third week wave 2 lucilla, wave 3 dermestes, এরকম ভাবে 4টে ওয়েভে আসে. You will have to mark these flies. Musca is house fly. So here is a mnemonic to help you out. My lovely dolly plays holy under the tree. মনে থাকবে? mnemonic মনে থাকবে না? mnemonic মনে থাকবে তো? easy mnemonic. হ্যাঁ. So M for musca, L for lucilla, D for dermestes, P for phaeophylla, H for hydratus, U for uropoda, tiniola and tineptio. ঠিক আছে? এই কটা waves of আরো আছে, but this at least you remember. And along with musca, you remember califora, first wave. Now, life cycle of, this is the last slide. So in case, no, second last slide. So life cycle of musca. Fly হচ্ছে, fly lays eggs. After eggs, 3টে larval stage. First instar, second instar, third instar. How will we differentiate? From the length of the larva. After that, pupa, and after that, fly. This is the life cycle of house fly, that is Musca domestica. In case of summer, within minutes, fly will come and lay eggs. In case of winter, 1 ঘন্টা লাগাবে. First instar 8 ঘন্টা, winter 1 দিন. Second instar 1 দিন, winter 4 days. Third instar 3 day, winter 8 day, pupa to adult 5 day. So total সময় লাগছে from an egg to adult fly in case of dead body in summer is 10 to 11 days and in winter 22 days. So if we can preserve the maggots, can we also find out time since death? Possible? So what we have to look from that, কি দেখতে হবে ম্যাগটে? এক তো লেন্থ অফ লার্ভা, রাইট, আর একটা টাইপ অফ ইনসেক্ট. টু ডু দ্যাট উই প্রিজার্ভ দ্য ম্যাগট. এখন ম্যাগটকে যদি আমি নিয়ে অ্যাসিটিক অ্যাসিডে ডালি, দ্য ম্যাগট উইল শ্রিঙ্ক, রাইট? সো ফার্স্ট উই বয়েল দ্যাট, বয়েল দ্য ম্যাগট, থ্রো দ্য স্যুপ, টেক দ্য ম্যাগট and preserve it in acetic acid solution. ঠিক আছে? তাহলে কি বুঝবো? লার্ভার সাইজটা বুঝবো. লার্ভার সাইজ বুঝে আমি কি করব? Why larval size is important? Exactly. কোন ইনস্টার, ফার্স্ট সেকেন্ড থার্ড কোন ইনস্টারে আছে জানার জন্য, রাইট? নাও এটা কি পোকা সেটা তো জানতে হবে. এটা ক্যালিফোরা না মুস্কা না আরো অন্য কিছু আছে সেটা. তার জন্য we need to take that maggot, larva, and take a piece of muscle and preserve that in a bottle so that the larva can feed on the muscle, and once it grows, from that we can know what kind of insect it is. তাহলে কি বুঝবো কোন ওয়েভে পোকাটা এসছে, and from that we can find out time since death, right? আচ্ছা, what will this puka do? Larva and maggot gulo, what will this do to the body? Will crawl inside the body, right? Make holes, and they will release enzyme. So those enzyme will be proteolytic, so they will hasten the decomposition. So এখনো অবধি how can we find the time since death? কি কি আমরা পড়লাম, that will help you finding the time since death. বলো কি কি পড়লাম? আর্লি সাইন্স, আমি সব করে একসঙ্গে বলছি. ইমিডিয়েট সাইন্স, আর্লি সাইন্স, রাইগার মর্টিস, Agar motis, liver motis, stages of decomposition, that is late signs. Apart from that, CSF, blood findings, vitreous humor, or pericardial fluid, hair, and forensic entomology. All of these things will help you find time since death. Okay? Now, this is the earliest internal findings. Under surface of the liver, greenish discoloration, and anterior peritoneal surface of right lobe of liver and adipose tissue around the gallbladder. So these are the two first signs of putrefaction. Acha, what is the surest sign of death? Surest sign of death. It is MCQ. পরীক্ষায় জিজ্ঞেস করে মাঝে মাঝে। Decomposition. Okay? Or putrefaction is the surest sign of death. So death as a chapter is over. Next class sign নেবেন হচ্ছে electric burn বা burn as a whole, and আমি নেব asphyxia. Okay? Any questions from death as a whole? বোঝা গেল? Can you find out time since death? Real life problem হবে না? Okay? Real life problem হবে না? Okay.
For exam purpose, theory as well as practical and oral purpose. And when you go to the clinics in the medicine department, this type of patient you can get very often in the clinics. And so you need this something, the concept for diagnosis and this type of patient which is suffering from alcoholic liver disease. So it is very important in the clinics for day-to-day life in your clinical work, and now for exam purpose, theory and oral purpose. So we will now switch on to these main topics, the alcoholic liver disease. You know the people are suffering from alcohol day-to-day their life. They are not listening to how much they have to consume or when to stop and what will be the complication if not stop. So we will learn these important topics today. So alcoholic liver disease. So what is alcoholic liver disease? It is a chronic spectrum of liver disease following the acute or chronic ingestion of alcohol. So it is a spectrum of the liver disease following acute or chronic ingestion of the alcohol is called the alcoholic liver disease. What is the spectrum of that alcoholism? It is a fatty liver or alcoholic steatosis or fatty liver. Alcoholic hepatitis, next step, if it is not stopped, then it progress to alcoholic cirrhosis. So it is a spectrum of disease of alcoholic liver disease. Fatty liver or alcoholic steatosis, then alcoholic hepatitis. If it is go further, it's not stopped, it is called the alcoholic cirrhosis. So this is the spectrum of disease. Now you have to know the alcohol metabolism. From the first year, from the biochemistry, you know the alcohol metabolism. What is the toxic agent? The alcohol is converted to aldehyde to acetate. This thing is injurious to the liver. So this metabolism, if it is goes further and further for prolonged period, give rise to the hepatic injury, and the complication of that hepatic injury produce this pathogenesis of this disease. See this? Main spectrum is this: ethanol is transformed to acetate by the enzyme alcohol dehydrogenase in the cytosol, alcohol aldehyde acetaldehyde dehydrogenase in the mitochondria, and 90% and 10% of this alcohol is metabolized in the body. So the first step is ethanol, when it is consumed, is converted from alcohol to acetaldehyde. Then in the pathway is the cytosol pathway, smooth endoplasmic reticulin pathway, then peroxisome. These are transformed to alcohol to acetaldehyde. And next step, after formation of acetaldehyde, they form to the in the mitochondria acetaldehyde to acetate. This is the basic concept for conversion of the alcohol to acetate. So this thing, the acetaldehyde, when it is alcohol is consumed, they transform to acetaldehyde in the peroxisome, in the cytosol and the microsome, and this acetaldehyde transformed to within the mitochondria, producing the as acetate or acidize in the circulation. What is the effect of this thing? It raises the formation of the acetylate adduct production, then increase the respiratory species, respiratory oxidative species, and increase NADPH, which form the NADH to NADPH. So these are the toxic materials they produce the pathogenesis of liver. Then how much alcohol they produce this toxicity? See, if the patient consume 80 gram of alcohol one or several days or month, they produce the alcoholic hepatitis or fatty liver or alcoholic liver disease. If the person they abstain from the alcohol with the proper food, they are reversible to produce a normal liver. If it is daily ingestion of 160 gram per day for prolonged period more than 10 to 20 years, they transform to a alcoholic hepatitis, and ultimately 10 to 20% of this or 15% of this thing, the alcoholic hepatitis, they produce the alcoholic cirrhosis. So this is the effect, bad effect or side effect of alcohol ingestion for prolonged period. Now, why it is hepatotoxicity? How it is produced? See this, when the alcohol is converted to acetaldehyde to acetate, they the toxic material they produce the decrease of NAD and increase amount of the NADH. That's the suppression of the fatty acid oxidation, so the fat will remain there. Increase synthesis of the fatty acid, then the implementation of the lipotoxin, lipoprotein, and increase peripheral conversion, that is the fat we ingested, they are metabolized to produce the fat. So everything is accumulated in the liver and produce this steatosis or accumulation of the fat due to alcohol ingestion. So in a diabetic form, so this is the alcohol produce acetate, helps in the increase NADH, and this NADH causes the suppression of the fatty acid oxidation, increase fatty acid synthesis, then increase lipoprotein assembled secretion and produce the accumulation of steatosis. And when it is coming from the peripheral blood, that is the ingestion of the fat, and they produce the synthesis of this thing, catabolism of fat, produce the circulation of this fat and produce the accumulation within the hepatocytes called fatty liver or steatosis. Then what are the risk factors for alcoholic liver disease? Risk factors are the drinking pattern. If the person drinking for 1 to few days, right, some of them are maybe concentration is in the reversible process. With food, it abstains from that thing, it will reverse the normal liver. But it consume more than 10 to 20 years, this alcohol gave rise to alcoholic steatosis at the fatty liver, then alcoholic hepatitis, and it is prolonged more than more years, 10 to 20 years, this irreversible liver disease produce the alcoholic cirrhosis. This is the bad effect of condition of prolonged period of alcohol. What are the other factors? The gender. The females are more prone to develop alcoholic hepatitis. The females are more prone to develop alcoholic hepatitis. And genetic factor. Sometimes the enzymes that are help for conversion of the alcohol to fatty acid, the alcoholic, aldehyde to acetate, the enzyme, if it is a genetically alteration of that enzyme, so any step they will accumulate and give rise to the accumulation of the fat. Then malnutrition, patient is malnourished, they are responsible for this risk factor. Next one, the infection. It is very important. If the patient is alcoholic, have the infection with hepatitis B and C, comorbidity, these things, they are most vulnerable for alcoholic hepatitis. So, infection, that is the hepatitis C and hepatitis B, they are more vulnerable to produce the alcoholic liver disease. More in hepatitis C than hepatitis B. Other associated with the alcoholism, the smoking also another vulnerable risk factor for this disease. Then risk factor, what I told, the alcoholic disease is a man, that is the 60 to 80 gram per day for 10 years. They will develop, and women 20 to 40 gram per day for 10 years, they are also prone to develop this disease. So alcoholic cirrhosis, this alcoholic hepatitis, 10 to 20% of these patients, they are prolonged to progress to irreversible change, produce alcoholic cirrhosis. So patient having the chronic alcoholic liver disease, the most complication is this thing, the alcoholic cirrhosis. It is the irreversible change. Then what is the pathogenesis? When the alcohol, the toxic agent from the alcoholic to acetase, they are produce the injury to the direct hepatotoxic injury to this thing, and they produce the effect on the microtubules, mitochondria, and the membrane of the hepatocytes. And this hepatotoxicity produce the production of the protein aldehyde adduct. The protein aldehyde adduct, that is the aldehyde product from the alcohol, they consume the adduct product from the protein. Formation of the MAA, that is the malondialdehyde acetaldehyde. Oxidative stress, that is the generation of the free radical. So all of these things produce the hepatotoxic injury and injury to the liver cells. Other factors are, that is the immunological mechanism, inflammation for the hepatocytes. When the alcohol consumed from the intestine, the endotoxin that are present in the intestine, they directly go to the liver, produce the pro-inflammatory cytokines. And these pro-inflammatory cytokines invites the inflammatory cells in the liver and produce the injury. They are the pro-inflammatory cytokines, they are TNF, alpha, TGF beta, IL-1 and IL-6. These are the pro-inflammatory cytokines. They insult to the hepatocytes and produce hepatocytic injury. Other than this, the fibrogenesis, the stellate cells present in the liver sinusoid, they activate and they produce fibrosis. So hepatic injury, inflammation, fibrosis, these are the complications of this, the liver injury. Other thing, the retention of, that is the metabolism of this alcohol acetate, they produce the water and the oxygen, also produce something. And this also as a whole produce the hypoxia and the hepatic injury. So these are the some nutshell of the hepatic injury following the alcohol ingestion. So these are the some presentation. Now, what is the morphology if the patient is suffering from the alcoholic liver disease? What is this spectrum? So this is the three morphological changes that occurs. Alcoholic steatosis, that is the fatty liver, alcoholic hepatitis, and ultimately this is alcoholic cirrhosis. If it is a healthy liver or normal liver, when it is produced, this is called alcoholic steatosis or fat accumulation. If the patient is abstained or it is withdrawn from the fat, alcohol, they reverse back to the healthy liver. If it is continued, alcoholic steatosis go to the alcoholic hepatitis. It is also reversible if abstained, and with proper food, this alcoholic hepatitis go to the healthy liver. But if the alcohol is continued for more than 20 years, 10 to 20 years, this will give rise to an irreversible change. That is the hepatic injury, fibrosis, liver is shrunken, all the function of the hepatocyte will lost and produce the alcoholic cirrhosis. This is very important. If we go to the clinics, we will see very often each and every bed these patients are lying down with the complication. They don't come to you in the early stage. They will come in the late stage with the complication. Then the liver is irreversible to treat. So it is a very important. It's important not only for the exam, for identify the patient, how you would diagnose the patient. It is more than 20-30% of this medical ward is full of this alcoholic liver disease. Now, what are the morphology? Then they have exam, they will ask, what is alcoholic liver disease? What are the toxic agents? How much they that produce the injury? How much alcohol will produce? What is the pathogenesis or morphology? Write down the morphology. Morphology means gross examination and microscopic examination. What is the gross examination? Alcoholic steatosis, that means it is the early stage. So what is this thing? Liver is enlarged. liver is enlarged, yellow, greasy, and the surface is the glistening capsule. This is the fat, so it is the smooth and slimy and the smooth, and it is the glistening also. That is the morphology, gross morphology. But when you see under microscope, what is this thing? See the accumulation of the fat. It is the empty space, that is the fat. Fat look like empty. If somebody asks in the exam, why not it is water? Why not it is a glycogen? Why it is an fat? So you have to differentiate by different state. If we do the fat stain, that is the oil rate or other fat stain, so it is confirmed that fat. If not stain, it is glycogen. It will do PL stain, then it is a glycogen. If not give positivity, so it is water simple. So the accumulation of empty space is simply maybe water, maybe a glycogen, or it may be a fat. So differential stain, you can differentiate what are the materials inside this. So when it is a fat that accumulate, they push the nucleus in the periphery. It is a small one, so there is a microvesicles. And these microvesicles accumulate and accumulate, coalesce to form a macrovesicle. So there is a micro, then it is a macro. Sometimes these macrovesicles coalesce to form a big cyst-like thing. So this is cystic fat. So this is the early stage of alcoholic steatosis. Only the fat they are accumulated. So it is an alcoholic steatosis. So these are the small vesicle. This is the large vesicle. Sometimes they coalesce to produce a large cyst. Now alcoholic hepatitis, that is the next step. Patient progress to a next stage that is called alcoholic hepatitis. Grossly, the liver is enlarged. So hepatomegaly, and it is also tender. And microscope, very important thing, what do you see? This accumulation of fat give rise to a hepatocyte injury due to the toxic material, and these hepatitis, that is hepatocytes, when it is injured, they are give rise to swelling and ballooning of the hepatocytes. And the cytoskeleton, that is the intermediate filament that present in the wall of the hepatocytes, they also deposited as Mallory body. So Mallory body within the hepatocyte are eosinophilic material. That is very important. So when it is a alcoholic hepatitis, the degeneration of the hepatocytes, that is the product ballooning of the hepatocytes, then accumulation of the Mallory bodies, that is the alcohol, that is the intermediate filament degenerated form, then give rise to, they invites the inflammation. So this is inflammatory associated with the inflammation. And sometimes they induce the fibrosis. That is the stellate cells, they also activated. They also give rise to fibrosis along the portal tract, along the central vein. They produce fibrosis and inflammation. So this is the hepatitis, the alcoholic hepatitis. Still it is an reversible. If not continued progress, it will be reversed back to normal if it is absent from the alcohol and with good food. So this is alcoholic hepatitis. See this is the liver is enlarged with the fat is inside. This is the inflammatory cells, this is this, the whole liver is undergo this inflammation. The hepatocytes is enlarged and then give rise to a ballooning of this cell. Hepatocytes is enlarged. And this is called the ballooning. And this eosinophilic material, this is called the Mallory hyaline or Mallory body. These are the intermediate filament. So this is the intermediate filament. This is the degeneration of this. Oral, they will ask, what is the Mallory body? This is the alcoholic hyaline material. Called the intermediate filament. Sometimes the MCQ also they ask. So this is the Mallory bodies or Mallory hyaline. Now the last stage. This is the alcoholic cirrhosis. That is the some of the patient give rise to irreversible change of this thing, produce the nodules. See the surface, it is the nodule. If it is alcoholic, they produce the micronodular cirrhosis. I'll come, what is this micronodule they form? I'll come. So this is the liver, give rise to this thing, the nodularity of this thing, and due to fibrosis, liver will shrink. Hepatitis and steatosis, liver is enlarged. But when the fibrosis is initiated, the liver is shrunk and give rise to a small size. So if we go to the ward, And then if we palpate, liver is impalpable or is sunken. But in the early stage, his liver is enlarged. So cirrhosis of liver, the size or weight of the liver is reduced due to fibrosis. Now what is the microscopy? Alcoholic cirrhosis microscopy is the nodular architecture. The hepatocytes, the liver has a nodular, it is the lobular architecture, has the well-placed central vein and the portal tract. But this is cirrhosis, the organization of this portal, disposition of the portal tract and the vein is disorganized. And the nodular architecture is totally lost and the liver is undergoes a loss of lobular architecture and the produce fibrosis, and this fibrosis is extend from central vein to central vein to portal tract, portal to portal in the happens of way and this thing. So with the degeneration or the necrosis of the hepatocyte, some of the viable hepatocytes, they are undergo proliferation. So the regenerated hepatocytes, they produce the rest, that nodule formation. So the fibrostic area, they undergo shrinkage due to fibrosis and the loss of hepatocyte, but the remaining hepatocytes, they are viable, they produce the nodular, that is the regenerated hepatocyte. That's why the surface of the liver or the whole liver lobular architectures are lost and produce a nodular hepatocytes. And the bile duct also undergo proliferation and necrosis. So these all the structure you can get as a whole. The hepatic parenchyma, surviving hepatic parenchyma produce the regeneration, the nodule formation, the necrosis of the bile duct as well, and bile duct also undergo proliferation. So this is microscopy. This is a normal hepatocytes. This is the portal tract. This is the central vein. This is a normal lobular architecture. What happened when this is the cirrhosis? This is the nodule formation. What I told you, this is the hepatocytes, they undergo necrosis and fibrosis, and the viable part remaining, they undergo proliferation and produce the nodules of different size due to fibrosis. Then if you are seeing this is a portal tract central vein, it very difficult to identify due to the fibrosis. So this is the character of a cirrhosis of liver, whatever may be the origin or etiology. Now the complication, that is the hepatic cirrhosis. See this liver, due to the alcohol, normal liver undergo this complication, thus the nodule of this liver surface produce the cirrhosis of liver. What is cirrhosis of liver? Then it is an irreversible chronic end-stage liver disease of various etiology. Cirrhosis is not only responsible alcohol, but the various etiology. So it is an end-stage liver disease due to the various etiology, and give rise to a characteristics. What are the characteristics? It involves the entire liver. Entire liver is involved. There is loss of lobular architecture, degeneration of the functional hepatocytes. So the necrosis or degeneration of that functional hepatocytes and formation of regenerative or viable hepatocytes, they produce the nodular architecture, and due to the formation of the fibrosis and hepatocellular necrosis of various etiology. So alcoholic cirrhosis causes alcohol, but it is a various etiology. So the definition will be a long-stage chronic degenerative liver disease of various etiology, characterized by such and such a thing. It will be the complete answer. So you can't write a cirrhosis is a 1 or 2 lines, but characterized by such and such thing with various etiology. So various things they produce the hepatic cirrhosis. Now what is the classification? Cirrhosis. One is macroscopic classification, another one is the etiological classification. Macroscopy, if in exam the liver is placed in front of you, they will ask what is the morphological classification? Maybe a micronodular type, maybe a macronodular type, or maybe a mixed. What is macro and micro? Less than 3 mm or more than 3 mm. So the micro and macro, if it is a mixed, So the mixture of both things will come. So this is a morphological. And etiology, so many things are there. They produce the etiological classification. Some of them thing is very important. You have to answer in the oral also. What are these things? Alcohol. Post-necrotic cirrhosis is important because the viral hepatitis B and C is important. Next, the biliary cirrhosis, hemochromatosis, non-alcoholic, that examiner will ask, is there any always alcoholic liver? No. Non-alcoholic liver disease are cirrhosis that can occur. I'll come later. Then other are this Wilson disease, alpha-1 antitrypsin deficiency, cardiac cirrhosis, then Indian childhood cirrhosis, cryptogenic autoimmune. So these are the, I told this is various etiology, cirrhosis, so these are the various type of etiology. You have to know the sum of some deficiency you will account it in your life. May not be a one or two, but very rarely we can encounter this type of thing. So this is the etiology is very important. Now what is this thing? How it is occurs? This when it is they produce the viral or it is a viral hepatitis, produce the hepatocytic change or inflammation that I told, give rise to alteration of the blood and lymphatic flow. This give rise to a hepatic fibrosis, already I told, and due to this fibrosis, the liver not assemble this the flow of blood and give rise to portal hypertension. The portal vein is produced from the splenic vein and the superior mesenteric vein. When they come to the liver, due to this pathology of the liver, they will not go inside this. So this is a portal hypertension. That next class you will learn what is the features of portal hypertension and how we identify the patient due to the portal hypertension. Some of these things I will show you a picture, but portal hypertension is a very big thing. You have to know the for theory class and also for oral, what is the feature of portal hypertension. So you will see in the word when you will go, the patient is come with the late stage with portal hypertension. So what are the features of portal hypertension that you can diagnose by seeing or examining the patient? That is very important thing. So what is this thing? And due to the portal hypertension, the patient is presented with ascites, edema, splenomegaly. Due to the splenic vein that also engulfs, this is the splenomegaly, esophageal varices, hemorrhoids. That is the portocaval anastomosis. Due to the portal hypertension, the portocaval anastomosis and mismatch. So patient presented is a profuse hematomesis and melena. In the umbilical area, they produce the engorged vein. This is a very important sign for portal hypertension. Often you can see in the ward also, the patient will come like this. Next, the liver function will disturb. So bilirubin metabolism will disturb. Next, due to this thing, the bile will not come to the intestine, or it may be urobilinogen is increased. Vitamin, the liver is produced, the vitamin K will deficient. So anything you have to handle the patient, you have to implement the vitamin K injection. Otherwise, patient will undergo the coagulation failure. Then metabolism of the synthetic product, that is the carbohydrate metabolism, protein metabolism, that will come. So patient is suffering from the hypoproteinemia. Due to this loss of oncotic pressure, patient presented with the ascites. So the cirrhosis patient, you will see a big abdomen with the fluid accumulation in the peritoneum, that is ascites. And it is due to the protein loss, it is an exudative, not, it is a transudative in nature. So cirrhosis of patient, the accumulation of the ascitic fluid, it is transudate in nature. Clear? Next one, the hormone. Hormone will imbalance. So estrogen will not metabolize, androgen blood pressure. Patient presented with a loss of hair, and the male patient presented with a gynecomastia. In the surgery ward, the male patient come to the ward as the enlargement of the male breast. See, if you exclude the cirrhosis of liver, this is a gynecomastia due to the hormonal dissemination of the hormone. Other thing, that is the liver function test, that is the SGOT, SGPT that also altered. And so alkaline phosphatase, due to the hepatic injury, all the enzymes that are also hampered. And ultimately, if it is a chronic or hepatic failure, hepatic encephalopathy, hepatorenal failure, and the hepatic coma and death. So ultimately, patient, if it is chronic one, give rise to a death. Hepatic encephalopathy, why it is called? The urea cycle is hampered. So ammonia will accumulate, produce hepatic encephalopathy. Aldosterone metabolism hampered, give rise to hepatorenal failure and give rise to coma and death. Patient emergency, these patients come to the emergency as massive hematomesis melena. So this is an acute emergency. So it is an exam point of view, and the medical ward is very important to identify the cirrhosis of patient. Now, what is the clinical picture? The early stage, the hepatic steatosis, mild alteration of the liver function test, and it is a reversible one if patient removed from the alcohol. Then alcoholic hepatitis, that is also some derangement of the liver function test, patient present with the mild sign symptoms, and it is also a reversible if it is withdrawn from the alcohol and with good food. But the cirrhotic patient, it is a very vulnerable one and go to the chronic stage. Then what is the prognosis of this patient? 5-year survival rate of this patient is 90% free of activity. If the patient is abstained from the alcohol, 90% may revert back thing, the alcoholic liver disease. But it is if it is advanced stage, that is the cirrhosis, the patient will go to the hepatic coma, hepatic encephalopathy, massive bleeding, hematomesis melena, intracranial infection, hepatorenal syndrome, and another more important thing is the hepatocellular carcinoma. So some of the patients undergo from the cirrhosis to hepatocellular carcinoma. See this thing? So patient presented with ascites, xanthoma, that is the bilirubin, spider angioma, that is the portocabal anastomosis, hepatomegaly, then palmar erythema, finger clubbing, ascites, pedal edema. These are clinical symptoms. Few you remember, but when we go to the clinics, you have to remember all those things to identify the patient. See this. So this is the spider. This is the caput medusae like this. As a portocabal anastomosis, patient is presented with this thing. This is the vein, they are engorged due to portal hypertension. Ascites, see this ascites, liver is normal liver undergoes this nodularity. And other features are also there. So cirrhosis of liver, if you go to the ward, you will see the patient is very difficulty. They are sitting or lying now with a big pot, big belly, due to their very much discomfort due to the accumulation of this fluid. So this is a very bad complication. So this is a nutshell of this thing. Healthy liver, alcoholic, that is the steatosis. If not removed, they go to the alcoholic steatohepatitis, and if it is reversible, go to the alcoholic hepatitis, then alcoholic cirrhosis, and ultimately sum of percentage give rise to hepatocellular carcinoma. This is the spectrum of alcoholic liver disease. Now how to diagnose? After that, that is a laboratory diagnosis. After the clinical examination, you do liver function test, everything, the hepatic function, that is the degenerative function, their detoxification function, all the are raised and give rise to alteration of the liver function test. Everything are seen. Then other than that, that is the blood test, you do protein will decrease, hypoproteinemia, then prothrombin time is prolonged. Liver, if you do liver biopsy, you can get the classical feature of this thing. Other things, the ultrasound, MRI, this will help for this thing. So these are the some laboratory investigation for diagnosis. Now come, alcoholic, one of the cause of etiology is the alcoholic liver disease. What are the other causes of alcoholic liver disease? These are the some important things. This is the post-necrotic cirrhosis, biliary cirrhosis, cardiac cirrhosis. This post-necrotic cirrhosis. What is the cause? Due to beyond the alcohol, these are the some infection. viral infection. This is the hepatitis B, hepatitis C, some drug induced, some other infection. So these are the causes, the necrosis of the liver and give rise to this. The microscopy, all the alteration are same, only the etiology is different. And the liver is a macronodular or mixed nodular cirrhosis. Alcoholic, it is the micronodular cirrhosis, but this is the macronodular or maybe a mixed. Non-alcoholic, sometimes the examiner will ask a silly question, always it is an alcoholic origin? No, it is a non-alcoholic. What is the cause? Due to a patient is the fatty patient, or it may be a diabetes patient, or it may be a obese, or it may be a high cholesterol. So these are the patients are vulnerable for this and produce the alcoholic cirrhosis or hepatitis. Sometimes patient will begin anger. If you ask it is an alcoholic illness, they will know. Then why would this produce? So it is a non-alcoholic. That is the answer. It is other than alcohol, they produce these same features due to alcoholic liver disease. Now, this is another important thing, that is the cardiac cirrhosis. Cardiac cirrhosis that is occurred due to the right heart failure. If the patient is suffering from the right heart failure, that is the passive venous congestion on the right side, and due to right heart failure, they will not pull the blood to the lung, so that is a passive venous congestion, and it will also give us to engorgement of the liver. What happened? If the necrosis of the hepatocytes around the central vein, so and the periphery around the periportal is the viable one, and give rise to a liver as a nutmeg. Give rise to a nutmeg. See, this is nutmeg, and this is the necrosis. It is the central vein. This is the degenerated hepatocytes, and this is the viable hepatocyte in the periphery. So give rise to a liver as a nutmeg type, and ultimately produce fibrosis and give rise to a cirrhosis of this thing due to passive venous congestion. The answer you have to know, what is the cause of nutmeg liver? It is the cause due to the passive venous congestion or right heart failure. So these are the causes you can see in the word. That's why you have to know this entity. Biliary cirrhosis, any obstruction of the biliary tree, maybe intrahepatic, maybe extrahepatic cause, produce the same thing, but it's a greenish type of liver due to bile congestion. It's one more important thing, is a biliary cirrhosis. Hemochromatosis, iron overload, give rise to a cirrhosis, chronic stage, that is another cause of the cirrhosis. Then alpha-1 antitrypsin deficiency, that is very important. If we go to the respiratory system, that is the emphysema. Due to this, the enzyme that protects the liver elasticity, they are originated from the liver. If it is deficiency, the elasticity of the lung will lose and produce the emphysema. So the very important thing, that is the alpha-1 antitrypsin deficiency. So these are the things you have to remember for oral exam. Next one thing, last complication, that is the hepatocellular carcinoma. That is the liver is give rise to this. Liver is different types of thing, produce the malignant changes, and this is the different types of grade of the hepatocellular carcinoma. When you go to the neoplastic lesion of the liver, that thing will come. And this is the etiology of this thing, that is the alcoholic liver disease end stage. Some of the things, viral hepatitis also give rise to this hepatocellular carcinoma. It is very important. Now, anything you can ask, any question? So this is important for exam purpose, for oral purpose. So this is the complication. Don't worry, if it is withdraw from the alcohol, some of the patient give back to the original one. But if it is continue more than 20 years, it will give us to a complication. So cirrhosis, alcoholic cirrhosis, if not treated, some of the percentage give rise to a hepatocellular carcinoma. Clear? Any question?